sessions of neurovascular clinics. So today I'm going to present about two cases of mechanical thrombectomy where there is an isolated occlusion of posterior cerebral arteries. First, we will see the two cases and review some literature about it. Are my slides moving, sir?
Yes, but it is not full screen.
Yeah. This one moving now?
Yes. No, okay.
Yeah, thank you. So here is a case, a 77-year-old male, a diabetic and hypertension. And according to his relatives, he was last seen normal at 10:30 p.m. And when he woke up in the morning, he has noticed left-sided weakness and difficulty in getting up. And he also noticed that he has to be in some altered sensorium. So he came to us around 10:30. The pulse rate was around 76 per minute with regular and blood pressures of 150/100. On examination, he was drowsy, arousable, and dysarthria, and he has left hemiplegia, left hemianopia, and NHS is around 12:13. So I've taken the diffusion weighted MRI because he is a wake up stroke kind of thing. We want to look for a diffusion flare, any mismatch is there or not there, take for IVT. And there is a diffusion restriction in the right cerebral peduncle and right occipital area. And flare started showing subtle changes in the right cerebral peduncle. So this is the angiogram of MR angiogram of the above patient. This angiogram is showing right PCA from proximal occlusion from the P1 segment.
Haskar, actually, we can't see the video.
Can you see the video?
I think you can share that particular window.
Oh, you have to share the particular window.
Okay. So we are seeing the PowerPoint
slides only. Okay, just one second. But how to share the screen? You have to restart the screen, right?
Yes. You have to end the sharing and once again share the video. Okay. Video is already open, right?
Yeah, video is open. It's playing now.
No, we can see. If it is open, you can select that particular window.
It's not playing.
Not seen.
Because it was playing till now. That's why.
You don't think you've shared the screen yet?
Is it seen now?
Yes.
So this is an MR angiogram of the same patient. Showing right side P1 occlusion. So can you see the PowerPoint again? So in view of the diffusion positive and flare started showing certain changes, we deferred IVT and we have taken it for that mechanical thrombectomy. So our hardware, sir, we use an 8F femoral sheath for guidance and 8F Fibiki long sheath, Navion support catheter, Phenom 21 microcatheter, Transcend 015 wire, and Vasco 10 microcatheter, and Catch Mini 20 centrifugal. So we have given the left subclavian injection, which showed the origin of vertebral artery is normal, but tortuous of left vertebral artery is seen. And we have exchanged over the extended length wire and we passed a Fibiki proximal segment and we have passed the support catheter Navion. And from this, we have taken an injection which showed the P1 occlusion on the right side. So this is after that we have put a micro wire and passed it and partial opening is there. And we have passed that we have passed the Vasac 10 and taken selective injection. This after passing our micro wire and removing, there is a partial opening of our P1 with there is right P1 stenosis and also some distal end of the P1 also some stenosis is seen. And then we have passed our catch finish 10 retriever here. One second. Can see the video here.
Yes. Yes.
So we kept our catch finish 10 retriever in the P1 segment, and we can start. We are retrieving that clot. And with that, after we achieved, and after that is a check injection showed the reperfusion of the P1 with proximal P1 stenosis. So that at that time we planned for tirofiban. We started tirofiban infusion for 24 hours, 12 hours after this procedure. And post procedure, we started injection tirofiban for 12 hours in view of that internal PCA atherosclerotic disease. And rest of the time, other stroke workup was normal. So 24 hours later, there is an established infarction in the midbrain and in the occipital area of the right side. But at the time of discharge, the left side power improved to 4/5 and dysarthria became better and hemianopia started improving. He was discharged on double antiplatelets and statin, and he is yet to be follow up during our course. And coming to our second case, he's a 69-year-old male with a diabetic and hypertension on medication complaint. He presented with sudden onset of right side upper limb and lower limb weakness with slurring of speech and decreased responsiveness. However, there are no history of headache, seizures, vomiting, and sphincter disturbances and trauma. So initially, he was managed at outside the hospital. He was a drip and ship model. CT brain they have taken. We didn't show any bleed. And IV thrombolysis was done with 10 hectoplasm, and then he was shifted here. And this is that angio showing. Can you see the angio? Okay, stop sharing.
No, you need to share the screen.
Sir, sharing, sir, sharing. Sir. In case that right side PCI got left side PCI got occluded, and there is an right fetal PCA is coming. So the MRI brain with angiogram showed left PCA territory infarct with P1 occlusion, and he was referred for mechanical thrombectomy. So on arrival, his GCS is E1, V1, M4. He is intubated in an ER, and there is right hemiplegia of upper limb 0/5 and lower limb 2/5, and right nasolabial flattening. And this, the diagnostic DSC we have taken, which showed both PCS are not visualized, and only what I was seeing is a superior cerebral arteries. This is a lateral view, and then doing a selective injection of that left PCA. And after passing the Stensolter stent retriever, we have opened up and left PCA we have opened up, and there is a reperfusion seen in that left PCA, whereas the right PCA has fetal PCA on the right side. There is a post-op diffusion MRI we have taken showing established infarcts in the left midbrain in inframedial temporal area. And this is the angio. After that, still remained patent. So on discharge, there is only mild dysarthria, upper limb power improved up to 3/5. He was started on double antiplatelets and statin. NHS is around 5 to 6 at the time of discharge. So this patient doing well. After 1 month after follow-up, is came to OPD with walking with support and all. And these are the two cases where we have done posterior cerebral artery mechanical thrombectomy, where there is an isolated PCA occlusion. Among that, very few case reports were reported, but on literature searching on the Western data, there are some case reports were there, where some case series were there, retrospective case series. So we'll have some outlook on about that mechanical thrombectomy and isolated occlusion of PCA. As we all know that endovascular treatment is established as first line treatment for acute ischemic stroke due to LVO in anterior circulation. And we all know that PCA occlusions were excluded in a recent randomized control trials on endovascular therapy to treat ischemic strokes. Compared to that, endovascular therapy versus best medical management, including IVT, whether endovascular treatment offers is beneficial or definite advantage over it, the role is unclear. But however, the MT is increasingly performed in PCA occlusions. So as we all know that PCA strokes are challenging to diagnose due to variability of symptoms, and patients are not always aware of their symptoms, making it more difficult to establish a timeline. Usually the occipital lobe, the inferior temporal lobe, and large portion of the thalamus and upper brainstem and midbrain are involved. So they lead to neuropsychological deficits and visual symptoms, and they significantly affect the functional independence and quality of life. And the incidence of PCA stroke can be estimated between 5 to 10%. So most common causes we all know it's cardioembolic, and thrombosis are generated either from atherosclerotic arteries, vertebral artery, basilar artery, or proximal PCA. It can be seen in dissections and small artery disease and other causes such as fibromuscular dysplasias. So LVO in the anterior circulation impacts the NHS more than posterior circulation, and ischemic strokes in the PCA territory have a distinct clinical presentation from carotid artery strokes. As we all know that current evidence that IVT can be received within 4.5 hours of the symptoms onset, and these recommendations come from clinical trials performed on broad spectrum stroke population. But however, that acute vascular occlusion on PCA and many cases were underrepresented and some cases were excluded. And this is a journal published in AHS Stroke Journal, where thrombectomy and thrombolysis of isolated PCA occlusion. They have done on 106 patients, which showed the positive effect on disability, visual, and cognitive outcomes with endovascular treatment. Just comparing with the endovascular treatment, the 3 months MRS and 3 months visual field normalization and improvement in cognitive domains were seen better compared to the best medical therapy and IVT. So the endovascular treatment has a good role, showed beneficial effect in improvisation of the visual fields and improvement in the cognitive domains compared with the best medical management. And this is that published in Frontiers in Neurology about that mechanical thrombectomy and isolated PCA occlusion. They have compared best medical management with intravenous thrombolysis and best medical management versus endovascular therapy. With endovascular therapy, a successful recanalization is seen in 52% of the patients, and they have seen early neurological improvement, that is early improvement within 7 days of procedure in PCA occlusion patients. And this is the one that early neurological improvement is seen in endovascular group around 61%, whereas in BMM it's only 35%. However, there is not much difference about the good outcome at the end of 90 days in form of MRS, but almost similar rates, 43 and 42%. So they say that EVT in isolated PCO appears safe and feasible, and have positive effects on clinical outcomes, primarily on the early neurological improvement, but also depend upon the initial stroke severity. And there's a recent article published in Acta Radiologica, where they have done thrombectomy of symptomatic isolated occlusions in P1 and P2. And they say 50% had a favorable clinical outcome after 90 days. And P1, P2 occlusion, doing an endovascular therapy or mechanical thrombectomy is safe and effective procedure. So as we all know, EVT is an established stroke. And regarding the endovascular treatment, there is no randomized data on PCA occlusion. And none of the pivotal trials included the PCA stroke patients. So in IVT at the present situation, intravenous thrombolysis and endovascular therapy in a combination can be offered in isolated PCA occlusion patient to maximize the therapeutic efficacy. So that's all. What are two cases where we have done that mechanical thrombectomy in P1 occlusions? Any questions on these things? Any questions or any queries regarding these things, or any?
If we have to sum up these presentations, basically, initially all these trials have been done for major vessels, and posterior cerebral artery and distal vessels have come up something relatively new. And one thing that has made it possible is the advancements in the type of catheters and materials which we use to remove these clots. So we have now smaller calibered microcatheters and stents. You call them as mini stents, which we have used here. So they go through very small microcatheters, and hence you're able to access into relatively smaller branches and get out that clot out from there. Another important thing is in posterior cerebral artery occlusions, usually the patients do not present very early. Maybe they recognize it quite a little later because some starts with visual problems. It is usually when they start having hemiparesis, that's when they turn up. So in posterior cerebral artery, if the patient is having hemiparesis, that indirectly means that he is probably having P1 occlusion, because that is where you expect the perforators and the thalamoperforators or the thalamo-geniculate arteries which come up from the P1 segment. So these are the critical areas which get involved if there is a P1 segment PC occlusion. So that's when they also would have some kind of hemiparesis. And if that is picked up earlier, like we were lucky in these two cases that we had picked these cases much earlier than the stroke had actually developed, then obviously you could limit the development of or the progression of the stroke by doing these procedures. Yes, the long-term outcome between the procedures and the best medical management as of now might not be too much of a difference, but early neurological recovery itself is an important thing which we have seen in these two patients. Obviously, that mitigates stay within the hospital and chances of having any secondary infections or any other secondary problems later on. So you get in early mobility of the patients, and early discharge is what you would be able to establish by these treatments. And also, if you see the post-procedural CT or the MRI, you would see that the stroke is limited to the areas which were seen earlier. So that definitely it saves that much amount of brain, which itself would have a positive effect for a longer term. So recognition is very important in posterior cerebral arteries stroke. So usually they come up delayed, but when they come up and if they have hemiparesis, remember that it could be proximal posterior cerebral artery occlusion, which can be taken up for mechanical thrombectomy because we have special devices or smaller devices to go into these branches and remove them effectively and safely. Thank you.
Any queries or questions regarding this procedure? Dr. Jaishankar, anything, sir?
Hello, Dr. Krishna.
Sir. Yes, sir.
Yeah, so I think very nice presentation
Thank you, sir.
and two good cases.
Yes, sir.
So one was thrombolized, right? The other patient was not thrombolized because flare changes were already there, isn't
Yes,
it?
sir. Yes, sir. Yes, sir. Yes, sir.
Do you have the follow-up of the second patient? The first patient is yet to come. Second one?
Second one, yes, sir. And 1 month follow-up is doing good, sir. After that, we have lost to follow-up, sir. Yes, sir.
No, I think I don't have much doubts regarding these two cases. So no comment, no more comments from my side.
Sir, what are the materials we usually use for PC? Like graded distal axis. Hello? Hello?
Hello, Dr. Krishna. Hello. Hello, Dr. Krishna. I think you're on mute. Can you hear us?
Yes, sir. Yes, sir. Yes, sir.
No, you have a question, so please respond to that.
Yes, sir. Yes, sir. Sorry, sir. I was on mute, sir. I was speaking. I didn't realize that I was on mute. So actually, these are this thing, sir. Ullas sir is online, sir.
Yeah, so basically you could, you have smaller devices as I just briefed about. So one of them would include this Vasco 10 microcatheter and the catch mini from the ball system. I think it is 3x20, it's not 4x20. Catch mini, stent and the Vasco 10 microcatheter systems are the smallest which is available as of now for us to enter into the branches. So these will be 0.17 inch microcatheter. So they're that small. You have other 21 based catheters in various other companies through which you can use a 4 mm stent retrievers as well. So those also would go for distal vessels. But in this case, initially, you can see that there was a 21 microcatheter which was used, which was not going through that tight stenosis which we had. So we had to change over to a 10 microcatheter system through which a smaller stent retriever was used. In all other cases, you could probably use any 21 microcatheter system and a 4 mm stent retriever to retrieve the clot. This you can see that there is a quite tight stenosis there with the angulation as well. So 21 catheter did not pass through this. So we had to change over to a 10 microcatheter system. Then it went past through that stenosis through which you could deploy a catch mini stent here.
Okay, thank you, sir.
Yes. Any other questions, or shall we wind up?
Is the gate wire used the same with the 10 micro catheter?
Yeah, it is the same.
Yes, sir.
Then if there are no further doubts, shall we wind up, sir?
Yeah, you can. Sir, we can wind up.
Yeah.
Thank you, Dr.
Thank you,
Krishna.
sir.
Thank you, sir. Thank you, Ullas, and thank you,
Thank you.
Pramod, sir.
Thank you, Lazar.
Jaishankar, sir.
Thank you.
Thank you, Dr. Jaishankar, sir. for
Thank you, Dr.
organizing this.
Jaishankar. Thank you so much.
Okay.